Good morning, everybody. Thank you, Dr. Jamila. Yeah, I was uploading the slides, and I was worried that it's not there yet, but yeah, it's there. Yeah, okay. So, so there are a lot of similarities between valve and valve and the native valve TAVI, but I'm going to focus mostly on the valve and valve. So, in terms of acquisition, the acquisition is the same, so we have to acquire a large area of data from like around the neck to the thigh. And the way we do it is usually the gated at the chest and then gated at the rest of the abdomen and pelvis. And then we can get a huge amount of data, including the aortic root assessment, aortic arch, descending thoracic aorta, and the axis. And you can see it there in 3D. I think the first step in assessment of valve and valve is to try to identify which valve type you are dealing with. Fortunately, most of the time you have a medical records there. You go there, you check surgical report, and you identify the valve. But if there's no surgical report, you have to familiarize yourself with what type of the bioprosthetic valve that's generated and you are trying to assess. Stented and non-stented, and the problem, there are some valves that have radio-opaque material, a lot of radio-opaque material, and some of them they have very little radio-opaque material. So it's just really very important to identify these valves. The second step is to identify what's the problem. And most of the time, what is the problem with the valve will be from the echo first, and then the CT can help also in identifying what is the structural abnormality that has happened. Is it something related to the valve itself or something related to something around the valve? Is it more stenosis or more regurgitation? Or there is some destruction because of infection? Because all these questions are important to decide about what sort of management is suitable for this patient, whether he should go for valve and valve TAVI or another surgery. So this is one way to see the bioprosthetic valves. Those are multiple types of bioprosthetic valve, and you can appreciate how much calcification there. And the more calcification in a valve, bioprosthetic valve, the more likely that this valve is stenotic and having gradients. But sometimes we don't have a lot of calcification, but more like a thickening. And again, if there is thickening like this, we have to differentiate if this is a thrombosis or this is just a degenerative thickening. Because of thrombosis, it might be treatable by anticoagulation for a while and it might resolve. But if it is degeneration, complete degeneration, and also associated with calcification, it might not resolve. And also to check if there is anything around the valve, because this is important also, because this patient might not go for valve and valve TAVI, rather he should go for another surgery. Then we have to assess the valve itself, and multiple parameters we have to assess. For example, the first one is to assess the size of the bioprosthetic valve. And the most important is to use the two orthogonal planes to have coaxial images of the valve and to measure the internal diameter of the valve. And we have to change the window level, so you reduce the blooming artifacts and you can see the internal diameter there. This is the diameter that will include the new valve. But again, we can also assess the LVOT, we can assess the height of the valve, we can see the height of the leaflets, we can assess the sinotubular junction and the height of the aortic root, and we can assess also the ascending aorta, similar to the what we do in the native valve. And also we can see the coronary arteries, and we'll see later. One of the most important areas of assessment is the assessment of the risk of coronary obstruction. And this is a bit complex, and you need to know the relationship between the bioprosthetic valve, which is inserted there, and its leaflets, and the coronary ostia. So the best situation where the coronary ostia are higher than the valve, relatively very high, higher than the valve, and the sinuses are wide. The more it is the sinuses are small or the ostia is below the struts of the valve or the leaflet of the valve, there is a risk of occlusion. And we can assess. So those are the anatomical factors, bioprosthetic factors, or transcatheter factors that can affect our risk for coronary obstructions. And there is a large international study that's called Valve and Valve International Data. They try to classify the risk, they classify the relationship of the valve to the coronary ostia and also the size of the sinuses, whether it is large or small or is effaced or there's shallow sinus, and there are classification there. And each classification, there is a risk which is either high or low risk of coronary occlusion. And so how can we assess this by CT? Usually what we do, we go to the top level of the valve, like this in the cross-sectional area, and we can assess the distance from what looks like a virtual valve. We put like a virtual ring, like a virtual valve, and we can assess the distance between this virtual ring and the coronary arteries. And anything less than 4 millimeter, usually it is a high risk of coronary occlusion. But this is in the normal situation. If you are like dilating the new valve or doing some maneuver to fracture the valve, which is there, the bioprosthetic valve, this distance has to be even larger. We can also assess this in the long axis there. We can see the top there, leaflet. We can see how narrow is the sinuses, and the distance between the valve and sinotuberous junction also is very small. So there are three distances: the valve, the bioprosthetic valve to sinotuberous junction, the valve to the sinuses, and the valve to the coronaries. All of them has to be adequate. So either there is a perfusion from within the struts of the valve or from above the valve. Ideally, you should have this sinus like in the red color, like there is a wide sinus there that allow the perfusion. But in this case, for example, it's very narrow and it does not allow perfusion. And there is very high risk of coronary occlusion, or even what we call sinus sequestration, because we are putting a valve inside a valve and there will be a skirt, and the skirt will just occlude the whole sinus and cause sequestration. This is from the same study that I mentioned. This is the Valve and Valve International Data, and the best predictor for coronary occlusion is the valve to left main coronary artery, for example, less than 4 millimeter. But there is evidence that other also measurement is important. And this is the schematic, is how to assess it. It's like what is the distance. If the distance is small, then you assess the size of the sinus. If it is small, if everything is small, you might consider like basilica or like laceration of the bioprosthetic valve leaflets, just to make sure that there will be no obstruction of the coronaries. Or if everything is good and the size of the sinuses is good, the distance is safe, you can just do conventional TAVI, like the same way we do the native valve. Ideally, I think in the future we should have all this automated, and we feed all this information to the computer, and the computer will give us all this information and will do modeling and will insert a valve inside that bioprosthetic valve which is degenerated, and will give us all the risk or simulated risk of all the coronary obstruction. Do we have it yet? I'm not sure that we have it yet, but I think we should in the future hear about it. The other area is the same, like I'm not going to spend a lot of time with this. The other area is just to see the access, if it is adequate access, because this is similar to the conventional TAVI. The access has to be adequate with a lot of calcification, tortuosity, or there is no significant narrowing of the access. So, and there is the good thing that there is an application there you can use for deciding about valves. So in summary, cardiac CT is crucial in planning TAVR, for patients with degenerative aortic bioprosthesis in terms of a precise measurement of the surgical valve internal dimension, valve structure, and the mechanism of degeneration. And we can also assess the whole aortic root and the axis. Thank you.
Thank you so much, Dr. Ahmed.